Okay, this is Professor Barrett, and this is a continuation of the lecture on that corresponds to chapter 37 in the Lewis textbook, because that chapter covers so much very important information. I'm splitting it into two lectures, so you don't have to sit for 2 hours and listen to the same topic. So the first half talked about coronary artery disease and stable angina, and now we're going to talk about acute coronary syndrome. All right, so acute coronary syndrome is basically an umbrella term that covers three different things: stable angina, and then unstable angina, and then myocardial infarction, which is a heart attack. And there are two specific types of myocardial infarction. That is a STEMI, which is an ST elevation myocardial infarction, and a non-ST segment myocardial infarction, also called an NSTEMI or non-STEMI. Okay, so the whole purpose of this lecture is we're going to differentiate amongst those three things: what they are, what does it mean, how do we treat it, what are the nursing implications of those things, okay? So we're going to look down here at these EKG complexes, okay? So we talked about in the first lecture on cardiac about the P wave here is um, the electrical tracing of activity through the atria. Then the QRS wave is the electricity traveling down the pathway through the ventricles. And then I talked about this segment between the S wave here and the T wave here, where the heart is repolarizing and relaxing and refilling in diastole, that this segment right here tells us about the coronary arteries being reperfused while the heart is refilling with oxygenated blood. So between the P wave and this little segment between the QRS wave here, this PR interval as it's called, we should be able on a normal EKG strip to draw an imaginary baseline between this PR segment where my cursor is right here across to that ST segment. So you can see there's kind of this imaginary line where they're all kind of on the same level. Okay. Now you'll learn in more detail about this in fourth semester, but just so you have a basic understanding, when we have the ST segment that is not meeting this baseline, which would be where this dotted red line is right here, it's above that baseline more than one little box on the EKG paper. We call that ST elevation. And when we see this in two or more continuous leads, that is indicative of an ST elevation MI, or what we call a STEMI. When we see that that ST segment is below that imaginary baseline, at least one little box on the EKG paper here, on two or more different leads on a 12 lead EKG, it tells us that the heart is not getting enough oxygen, and we call that a non-ST segment, a non-ST elevation MI, or a non-STEMI or an NSTEMI. Okay. So, difference between those things we're going to talk about. Okay. So, coronary artery disease is um, comprised of chronic stable angina, which we talked about in the coronary artery disease section, and then acute coronary syndrome. So we're talking now about acute coronary syndrome. which is unstable angina or a non-ST segment elevation MI or an ST segment elevation MI. We're going to look at the pathophysiology of those, but ST segment elevation MIs or STEMIs, as you can see, are off on their own little box here because ST segment elevation MIs or STEMIs are like full thickness injuries of the cardiac muscle and are much more deadly, much more dangerous than the other types of acute coronary syndrome. Okay, so when we have patients come in with chest pain, well, first thing that we're going to do is, besides getting vital signs on them, we want to make sure that we get a 12-lead EKG. If there are ST elevations on the 12-lead EKG, they most likely are having a STEMI. We need to make sure if there's previous EKG history available that we're comparing their current EKG to their previous EKG to see if this is a significant change. But usually when we have the ST elevation on the EKG, it's telling us that there's myocardial injury that is potentially reversible, which means if we can intervene and get the artery open quick enough, we may be able to save some or all of that heart tissue that is experiencing a lack of oxygen. Okay. But typically, what produces the STEMI on the EKG tracing is that there is a total coronary occlusion, and the cellular response to the lack of oxygen and glucose deprivation is that anaerobic metabolism starts to occur, increased lactic acid is produced, and that within about 20 minutes, permanent damage will happen to those cardiac muscle cells and the heart will be damaged. And in some cases, if it's bad enough, if enough tissue is injured, the patient may not be able to survive that, may go into cardiac arrest, and we may not be able to get them back. If we can get the artery open and get that tissue reperfused and aerobic metabolism can happen, then contractivity, heart activity can resume, and the heart might be able to repair some of the damage that was done. If we see ST segment depression, or if that T wave in diastole where the heart is refilling and repolarizing is upside down, then it probably indicates an unstable angina event or an NSTEMI. And the way that we're gonna tell the difference between those two is that in unstable angina, a patient is gonna have ST depression or the T wave inversion, but when we check their blood, certain biomarkers called troponin will be negative or not be elevated. But with an NSTEMI, we have the EKG changes plus we have the biomarkers in the blood. So unstable angina is EKG changes of ST segment depression and or an inverted T wave. And NSTEMI are the same EKG changes plus elevated troponin level in the serum. Okay. So, what happens usually when we have acute coronary syndrome is that we have deterioration of a once stable plaque that leads to rupture. So, we have atherosclerosis, and then we have plaque formation, and then that plaque ruptures, breaks off, has platelets gathering around it to try to repair. It's now forming a big clot. that clot gets pushed in the circulation and will get lodged inside one of the coronary arteries and obstruct it. If some blood flow can still get around the occlusion, then it's going to show up as unstable angina or an NSTEMI on the EKG. If it's a total occlusion of the artery, then it will show up as a STEMI on the EKG. Okay, so here are some other pictures of the EKG strips where you'll see ST depression. And here's what that inverted T wave looks like. So instead of being upright like this, the T wave inversion will be deflected the opposite direction. Okay, so with unstable angina, chest pain occurs and it might not be pain, it might be pressure or just discomfort. Some people will think that they're having indigestion, but a lot of times this might be the first clinical sign that people even realize that they have coronary artery disease. Usually with unstable angina, the pain is lasting greater than 10 minutes and is not getting better. It's unpredictable. It's still hurting with activity and at rest. It needs immediate treatment. The EKG will show ST depression and or T wave inversion, which means there are ischemic changes. Ischemic changes meaning that there's evidence on the EKG that the coronary arteries are not able to supply enough blood to the myocardium to keep up normal cardiac activity, and the muscle will soon be injured because of anaerobic cellular respiration. And then remember the key here is that with the stable angina, we have these readings on the EKG, but our biomarkers in the patient's blood, so our troponin, will be negative. All right. The other side of acute coronary syndrome is myocardial infarction, also known as a heart attack. We're going to refer to it as an MI for short. Okay, so we have ST elevation and non-ST elevation MIs. Result again of abrupt stoppage of blood flow through coronary arteries. So remember when we're talking about coronary artery disease in the first part of this chapter, and we were talking about chronic stable angina. This is chest pain that kind of comes and goes with physical exertion because of what we call demand ischemia. The heart muscle is using more oxygen than the body can give to it. But the body also has time to adapt to this. So once the body rests and the demand goes down, the chest pain goes away. But with MIs, with STEMIs and STEMIs, this is a rapid, abrupt stoppage of blood because of a clot that is caused by platelet aggregation on a pre-existing area of an area where there's been atherosclerosis and fatty deposits. Okay. So once the obstruction, when the clot breaks off and forms an embolus, which is a clot that breaks off and is pushed through the circulation, gets lodged in another area, then it's rapidly obstructing the oxygen flow, and then myocardial cell death happens very quickly, typically within 20 minutes. So again, with the STEMI, the artery will be completely occluded, and the NSTEMI, it's not completely occluded, it's just partially obstructing the flow of blood. Okay. So you can see on this picture is the a dissection of a real heart where there was the infarcted area, and then you see the dead tissue in here as the result. All right, so a STEMI is a medical emergency. All MIs are medical emergencies, but in particular, STEMIs, because there is a complete occlusion of the coronary artery, and if we can open that artery back up, there is a good chance that some of the cardiac cells can be saved. So there's a national benchmark of door to balloon time, is what it is called, of 90 minutes. And what that means is that we either need to get a patient from the time that they come into the emergency department at the hospital into the cath lab and be doing an angioplasty on them to open up that artery within 90 minutes, or giving them a thrombolytic to help break down that clot within 90 minutes. An NSTEMI is not as urgent because there's not a complete occlusion of the artery. The standard of care for percutaneous intervention or getting the patient to cath lab for angioplasty is within 12 to 72 hours. When a patient has either type of MI, we're going to be wanting to look at an echocardiogram so that we can look at if there is decreased movement or the inability of movement of the muscles in infarcted areas. That will help give us an idea of how much damage was done to the myocardium during the lack of oxygen that caused the MI. The degree of left ventricular dysfunction depends on the area of the heart and the size of the infarction. So, if the infarction was in an area that is not supplying blood to the left coronary, to the left ventricle, then that muscle in the left ventricle may be spared and able to still function, right? The evolution of an MI usually the cardiac muscle will start having some ischemia, so a little bit of a lack of oxygen before it goes into full infarction, which is the tissue death, right? So it usually takes about 4 to 6 hours to have full thickness necrosis. So it's really important for patients to get in as soon as possible. The problem is that usually people doubt the symptoms that they're having unless it's like a massive MI where they just feel like they cannot breathe. It feels like somebody's sitting on their chest. It feels like their heart is in a vice. Those are the people that are getting brought in right away, and or because they've gone into cardiac arrest and somebody's calling 911. But there are many people that wait at home for days with ischemic changes in their heart. So I would always tell patients, if you have chest pain, get it checked out. If you think you're being silly and people are going to give you a hard time, then so be it, but it's better to get it checked out. Okay? When people are having MIs, it's described by the location on the heart, either anterior, inferior, lateral, septal, or the posterior wall of the heart. And the location of the MI and EKG changes correlate with the involved artery. So you can look in your book. You can learn more about that in fourth semester. I'm not going to hold you guys accountable for knowing which leads on a 12 lead indicate ischemia or infarction in which coronary arteries. If you want to go on and be a critical care nurse or you want to be an NP, then you can learn that. But for right now, it's enough to just understand that the different leads on a 12 lead do correspond to different coronary arteries. So when we see in ST elevation or ST depression on certain leads on a 12 lead, it tells us a lot about which vessels are affected by the occlusion. All right, chest pain that is not relieved by rest, position change, or taking quick release sublingual nitro is the most common indicator of an MI. Okay. People will often complain about heaviness, pressure, tightness, crushing, burning, constricting type feelings, usually substernal or epigastric, so middle of the chest or right above the stomach area. It may radiate to the neck, lower jaw, arms, or back. Most often, MIs occur in early morning and last for greater than 20 minutes of chest pain without getting better. In women, symptoms tend to be more atypical, might be more just like extreme fatigue, nausea, sweating, things like that, and not necessarily pain. We do have to be careful with our diabetic patients that have cardiac neuropathy. So they might actually have nerve damage they don't even know about. That when they start having ischemia or infarction in their heart, they are not able to feel pain with it because of their neuropathy. Um, so usually when people start having an MI, the sympathetic nervous system reacts by releasing catecholamines like epinephrine and norepinephrine. So this causes symptoms like diaphoresis, which is sweating, increased heart rate, increased blood pressure, vasoconstriction of the peripheral blood vessels. This is all in an effort for the body to shunt as much blood as it can to those coronary arteries to try to preserve the heart muscle. People's skin might look ashy or dusky, clammy, or cool to the touch because of poor peripheral perfusion. Initially, when people are having an MI, they tend to have an increased heart rate and increased blood pressure. And then after, when they start having decreased cardiac output and their sympathetic nervous system starts to kind of get tired and calm down a little bit, their blood pressure starts to decrease because of decreased renal perfusion. With the decreased cardiac output, they'll start having decreased urine output. They'll probably start having crackles in their lungs because their heart is not pumping effectively while this is going on. So fluid starts backing up into the lungs. We'll start to see symptoms of right-sided heart failure as well, jugular vein distension, hepatic engorgement, so maybe right-sided abdominal pain and peripheral edema. We may hear abnormal heart sounds, so those S3 or S4 gallops, and we may hear new murmurs. So, nausea and vomiting again, very common during an MI. It's stimulation of the vomiting center, both by severe pain and by the release of the epinephrine and norepinephrine. Um, the vasovagal reflex is activated. When this happens, people often will start having fever in the first day or two because of the systemic inflammatory response that is happening with the heart cell death. All right, the healing process of an MI. Okay, so The inflammatory process will start once the MI occurs. Within 24 hours, white blood cells will go to the area of cell death and start releasing enzymes. The enzymes begin to start to remove some of the necrotic tissue. And then by the fourth day, that results in a thinning wall of the necrotic tissue. Then we have an increased glucose response because of catecholamine, again, activation of the sympathetic nervous system. So blood glucose starts to go up. We can start to see the areas on the EKG that have been affected by the necrosis. And then collagen creates scar tissue over the area of tissue that was um, that was injured. And as you can think about, like collagen is tough. It's not very flexible. It provides a pretty firm structure. So where the heart muscle is very compliant and very elastic and has to pump, when we have collagen remodeling over that damaged area, it makes the pumping, the contractility of the heart a little less compliant or responsive over time. And so this is how the healing process of an MI can also contribute to heart failure after an MI. All right, so for 10 to 14 days, the patients have to really take it easy because that scar tissue is still very weak and we don't want any rupture to go on with that healing process. The heart muscle is extremely vulnerable to stress for the first 2 weeks after an MI. Patients need to be monitored very carefully as their activity level increases. By about 6 weeks, we would say that the MI scar tissue has replaced the necrotic tissue and it should be healed. And then but unfortunately, because of that process, some ventricular remodeling will have happened. So the normal cardiac muscle or myocardium will be a little bit strong, a little bit bigger, hypertrophied and or dilated in an attempt to compensate for the loss of muscle, which can contribute to heart failure. All right, so complications of MI, dysrhythmias. So about 80 to 90% of MI patients also have dysrhythmia with or after their MI. It can be caused by ischemia, different electrolyte imbalances, or just all the activation of the sympathetic nervous system that is going on. The most common arrhythmias are ventricular tachycardia and ventricular fibrillation, or VTach and VFib. Um, and those are the most common things to happen like while the MI is going on, and those things would put the patient into cardiac arrest. Again, another I've mentioned before, common complication of MI is heart failure. So because of the damage to the muscle, heart now has decreased pumping power. Left-sided heart failure, again, we're going to see some problems with gas exchange, some anxiety, restlessness because of the feeling of shortness of breath that comes with the pulmonary congestion. We might hear some S3 extra heart sounds. That's the heart sound that sounds like Kentucky. We might hear some crackles. We'll have the paroxysmal nocturnal dyspnea, which is the having trouble, shortness of breath at night that comes and goes, and then the orthopnea, having trouble with shortness of breath when laying flat. And then if there's right-sided heart failure, we'll see the jugular venous distension, hepatic congestion presenting with right-sided abdominal pain and maybe some ascites, and then the lower extremity peripheral edema. Cardiogenic shock can happen related to MI, and this is because of the immune response, I'm sorry, the inflammatory response to the death of the heart muscle. For you guys, it is enough to know at second semester that a complication of an MI is that the patient can go into shock, which means their body is not able to regulate its own blood pressure, and we have to take over. It is associated with a high rate of death, so we want to make sure that we're monitoring for symptoms of shock and watching just the patient's Sears criteria, just like we would for a patient that has an infection that we'd monitor for sepsis. When somebody has an MI, we're going to look for the same symptoms of making sure their blood pressure is stable, their heart rate, their oxygenation, their temperature, and making sure their lactic acid levels are normal, that their body is doing good aerobic um, respiration and energy production. You don't need to know the pathophysiology of cardiogenic shock now. You will learn about that in fourth semester. Another complication is papillary muscle dysfunction or rupture. So remember when we talked about anatomy and physiology, the papillary muscles are those muscles in the ventricles that have the tendon cordae attached to them that are kind of like the strings that pull the AV valves open and shut, the mitral and the tricuspid valve. So if there's dysfunction or rupture of those, then we'll hear new onset murmurs and can contribute to heart failure as well. Left ventricular aneurysm. So when the myocardial wall gets thin because of remodeling, it can bulge out, and during contraction, it can have a rupture and cause more blood clots, which can lead to heart failure, dysrhythmias, and another MI or angina. Ventricular septal wall rupture and left ventricular free wall rupture. So this is basically when the wall between the left and right ventricle, the septal wall, gets so thin that it breaks, and then there's no separation between the right and left ventricle, and then unoxygenated and oxygenated blood would be mixing together in the ventricles, and it can lead to shock and death. Pericarditis. So remember when we talked about the pericardial sac that's around the heart, right? When there's inflammation of the pericardium, there can be extra fluid in there that surrounds the heart. And when that happens, it doesn't allow for the muscles of the heart to have space to contract and expand properly. So it produces this sound that we call a friction rub that we listened to in one of the previous lectures. And it can create a situation where the patient has very poor cardiac output because of the restrictions of physical space restrictions put on the heart. Dressler syndrome is pericarditis, so inflammation of the pericardium and a fever that develops within the first 2 months after an MI that is thought to be an autoimmune condition. It doesn't happen to everybody, and we don't really know why it happens to some people and not to others. But these patients, after an MI, might start developing sudden chest pain, fever, be very kind of malaised. They may have a friction rub when you listen. They might start having trouble kind of moving and talking and have an increased white blood cell count, and their ESR or SED rates that indicate overall inflammation in the body would be elevated, and typically that is treated with high dose aspirin. All right, so here's a little acronym for the complications of an MI. All cardiac patients suffer TRAP, and that stands for arrhythmias, congestive heart failure, pericarditis, cardiogenic shock or shock that's cardiogenic, thromboembolism, rupture, aneurysm, and post-myocardial infarction syndrome. So it's not a perfect acronym, but if you're having trouble remembering what all the potential complications are, maybe this will help you. If it doesn't, then don't use it. All right, what diagnostic studies do we use when we're investigating an MI? We always want to get a detailed health history from our patient. We want to get a 12-lead EKG and be able to compare it to an old one if possible. We're going to look for changes in the different waves and segments and be able to distinguish between a STEMI and an NSTEMI or unstable angina. And then we're going to check serial EKGs to see if things are changing so we can see if the MI is progressing. We're going to get blood draws to check troponin levels. Troponin levels are a separate order from like basic chemistries. So expect that it will be a separate order. It won't just show up on a comprehensive metabolic panel. Um, it will start to the troponin level. So troponin is a protein that is released by cardiac muscle that are undergoing anaerobic cellular metabolism. So when that troponin is released into the bloodstream, it is an indication to us that there is cardiac muscle ischemia going on and damage occurring to the cardiac muscle. We start seeing troponin elevated in the bloodstream of patients having an MI within about 4 to 6 hours. So sometimes people will come into the ER complaining of chest pain. We'll check a troponin on them. It's negative. And then if we check 4 to 6 hours later, all of a sudden now the troponin is positive and may go very high, very fast, right? So if we have chest pain and EKG changes, but no positive troponin, so no troponin elevated, then we're going to call it unstable angina. We're still going to treat the patient, and investigate if there's a blockage in their artery and have them follow up with cardiology, but it's not going to be as an emergent. We're just going to give them like vasodilating drugs like nitroglycerin, pain medication, and some fluids to help their cardiac output and have them rest. Okay. There are other cardiac biomarkers, CKMB, which is creatinine kinase, that is a waste product of muscles that is specific to cardiac muscles, or myoglobin, which is generalized protein released from injured muscles. But the troponin is the most sensitive to cardiac cell tissue damage and death. So that is the cardiac biomarker of choice to look for with chest pain patients. And then cardiac catheterization. So again, PCI is the percutaneous intervention where we take them to cath lab and use the scopes, the catheters to look in the arteries. We use contrast dye to illuminate the vessel so we can see where the blockage is. If there's a blockage, the dye is not going to get through there, and it helps illustrate where the intervention needs to happen. With a STEMI, our goal is to get the patient into their angioplasty and get their artery opened up within 90 minutes. If there's no available option to do a PCI, so they're in a place where there's no cath lab, no interventional cardiologist available, then thrombolytic therapy within 30 minutes. Within 12 to 72 hours is when we want to take patients to the cath lab when they have unstable angina or an end STEMI. If the PCI interventions are unsuccessful, then they may get a referral for coronary artery bypass grafting surgery. All right, and so this is just a visualization of what the cardiac biomarkers look like typically after an MI. So you can see that typically myoglobin will start to elevate first, but it doesn't show up in the blood for very long, and it's not a super reliable marker for cardiac muscle, just for muscle injury in general. CKMB is specific to heart muscle, but as you can see, it doesn't elevate as much or show up in the blood for as long. And troponin really peaks really high when cardiac muscle is injured and stays in the bloodstream for about 2 weeks. So it's a really good marker for us to see how the heart muscle is doing. All right, emergency care. When we have patients come in for chest pain and we are suspecting acute coronary syndrome situation, the emergency care is to get a 12-lead EKG, keep the patient in an upright position to protect their airway, give them oxygenation to keep their SATs above 93%, make sure that they have good IV access, and wherever I've worked in cardiac areas, we always wanted two peripheral IV sites for chest pain patients that might be going to the cath lab. We want to make sure that we're giving them sublingual nitroglycerin to create rapid vasodilation, and then chewable aspirin to stop the platelet activity of those occlusions in the arteries getting any bigger. We don't want more platelets sticking to them. We're going to give morphine for pain relief and because it has vasodilating properties. And then we're going to see if they're on a statin. If there's an emergency situation where patient's having a STEMI, we're not going to worry about statins. But if this is an unstable angina, or NSTEMI situation, we want to get them started on a statin as soon as possible. So there's an acronym called MONA for Emergency Care of Acute Coronary Syndrome, which stands for morphine, oxygen, nitroglycerin, and aspirin. The bottom picture here I added that says ONAM. MONA is so much easier to remember, but ONAM is actually the order in which you would do these things, right? So you would give the patient oxygen first, right? Because of our ABCs, right? And then nitroglycerin, right? Because airway and breathing trumps circulation issues. Then we would give aspirin, and then morphine we would take care of last. So we don't want our patient to be in pain, but when we have to make a priority between airway, circulation, and pain, then we have to go with our ABCs, right? And address the airway and breathing first, then our circulatory issues with our nitroglycerin and aspirin, and then we'll deal with the pain last. A word about nitroglycerin and chest pain patients. I think I've mentioned this before, but you always want to get your 12 lead EKG before you give the patient the nitroglycerin because dilating the coronary arteries with the nitroglycerin can mask ischemia or infarction on the EKG. So the STEMI or NSTEMI may not show up on the EKG the same way if you do it right after giving nitroglycerin. So you always want to get the 12 lead first and then give the nitroglycerin, but oxygen first always. All right, some nursing interventions for emergency care of chest pain patients with acute coronary syndrome. If the ECG shows ST elevation, make sure to activate whatever the protocol is for the cath lab to get ready. Um, if the ECG shows ST depression or T wave inversion, make sure that we're getting patient to critical care or a telemetry unit as soon as possible. We want to monitor for dysrhythmias and treat per whatever the agency policy is. We're going to monitor serum biomarkers, so expect to see troponin levels drawn every 6 hours on your patient, and they'll continue to be drawn until they peak and then start trending back down. So they may be drawn for a couple days depending on when the patient's troponins peak. So for with blood thinners, for unstable angina and NSTEMI, the patient we do expect them to be on heparin or a glycoprotein 2B3A inhibitor, which is a very fancy way of saying an IV blood thinner that is not heparin. It's the different classes of medications that act as blood thinners. One of the common ones that we'll see are Repro, Integralin, Aggrastat. For a STEMI, usually during the procedure, they'll have them on one of these drips and then usually take them off of it once the intervention is done. All right, so this is actually from your book, so you can look at this in your book if you want, but this is just kind of a visualization of the different lab tests and interventions that nurses can expect to do with the different parts of stable angina and then coronary artery, or sorry, acute coronary syndrome, which is either the unstable angina and non-STEMI or the STEMI. So this is all stuff that we've already gone over, just a different way of looking at it. So you can go back to the slides and look at that for studying if you'd like. All right, so we can expect that these patients are going to be admitted to either the ICU or a telemetry unit, that they're going to have frequent vital sign checks, continuous pulse ox, continuous telemetry ECG, serial 12 lead ECGs. Again, why would we need to have continuous telemetry and serial 12 lead EKGs, meaning that we're doing them roughly every 6 to 8 hours? Because again, with the 12 lead, the different leads correspond to the different coronary arteries and how they're doing. So the continuous ECG or the telemetry gives us ideas if people are having any dysrhythmia, but the 12 lead EKGs are really helpful in telling us about the perfusion of the coronary arteries. We're going to do serial cardiac biomarkers, so expect troponins to be drawn every roughly 6 hours. Patients will be on bed rest or have limited activity for the first 12 to 24 hours and then gradually get to increase their activity. For unstable angina and NSTEMI, heparin is very common. For NSTEMIs, when patients are on a stent or get a stent placed, they'll be on dual antiplatelet therapy, which is aspirin and Plavix together. If it's just unstable angina, they may just be on aspirin, but most docs these days like to do the dual antiplatelet therapy of adding the Plavix in as well. They'll plan to take them to cardiac catheterization with the unstable angina or NSTEMI within a few days once they're stabilized. And until that time, they'll just do medical management to reduce the workload on their heart so that they're not incurring more demand ischemia. And then when they're more stable and rested, they'll take them to the cath lab to do an angioplasty. And if they're not able to do that or that's not successful, they'll be referred to a cardiothoracic surgeon to be considered for open heart surgery to do coronary artery bypass grafting. Okay. So the most important thing with STEMI again is to get the artery reopened with that emergency cath lab procedure, that emergency PCI, do the angioplasty. That is called, another term for it is reperfusion therapy. Okay. So the first treatment with STEMI is always the first intervention is always get them to the cath lab and get the artery open. It's very rare that they'll do an emergency cabbage on a patient. If they're unable to do the catheterization for whatever reason or it's not successful, they'll admit them to the ICU and they'll use devices and drugs to keep their heart working as best it can. You guys will learn about that more in fourth semester. You don't need to worry about it now. Right now, what you need to make sure that you understand is just that the advantage of doing the cardiac cath, the PCI, versus an open heart surgery and doing the artery bypass grafting is that it's faster, there's easier recovery time, faster getting back to your life, less risk for infection. So, a lot of advantages of doing the angioplasty over the cabbage if the patient is able to get the angioplasty and get stents placed. Different complications of angioplasty or PCI is that can cause dissection or rupture of the artery when they're placing stents or using the catheter in there. It can cause abrupt closure of the artery. We can get clots that form in the stents that they're placing. And it can make the occlusion worse. So hopefully none of that happens, but we always think about it like the risk versus the benefits. And if we don't intervene at all, the patient is going to die in a very short amount of time if the coronary arteries continue to be obstructed. So anything we can do is making it better. So the risks are worth it because the alternative is that the patient is not going to live very long. Thrombolytic therapy, so medication that breaks up clots. It is indicated for STEMI, but it's only used if we can't get the patient into a cath lab within like 2 hours. So this happens sometimes when patients are in rural areas or places where there's just not the right equipment or the right professionals to be able to do PCI. In that case, we can use thrombolytics just like we would with a stroke. Okay. So the goal, if they have to use thrombolytic therapy, the goal is just to limit the size of the infarction, keep the clot as small as possible so that blood can get around it in the circulation. People that meet criteria to have thrombolytic therapy are people that have had chest pain less than 12 hours, and their 12 lead shows a STEMI. Again, because there are a lot of risks of bleeding with thrombolytic therapy, because it is going to be systemic that we're giving these thrombolytics. We just want to be careful with when we're using them and who we're giving them to. So we only use them, the risk we only feel is acceptable when the artery is completely occluded in a STEMI and we don't do anything, the patient's gonna die. All right, if the patient is getting thrombolytic therapy, we would want to make sure that we're getting baseline labs, that we would have 2 to 3 lines for IV therapy, that we have any invasive procedures that need to be done have to be done before we give the thrombolytics because of bleeding risk. We're going to monitor heart rate, rhythm, vital signs, pulse ox, assess heart and lung sounds, and neuro status. When we know when it starts to work because we're checking 12 lead EKGs and we start to see that ST segment returning to that baseline. So we're not seeing the ST elevation anymore. The chest pain starts to go away, and then we start to see the peak of the troponins within 12 hours, and then they start trending back down. And then let's see. Yeah, those are the important things. Major complication is bleeding. All right, so drug therapy. So if patient has an NSTEMI or unstable angina, we're going to treat with dual antiplatelet therapy. So aspirin and Plavix. We're also going to give them beta blockers, calcium channel blockers, ACE inhibitors, and or nitrates like nitroglycerin. So these folks are going to be on several cardiac medications when they leave the hospital. We may give them IV nitroglycerin while they're in the hospital to maximize reperfusion of the heart since it's a direct vasodilator. Morphine if they're having chest pain, again, because it also has vasodilating properties. Beta blockers to slow down the rate of the heart so the heart can refill more when it pumps. ACE inhibitors or ARBs, they only get one or the other to break that RAS cycle so that we limit extracellular fluid and prevent vasoconstriction. We're going to give them antidysrhythmic drugs if they start having dysrhythmias. We're going to make sure they have statins so we can combat their existing coronary artery disease or atherosclerosis from getting worse. We can't fix it, but we can keep it from getting worse with statins. We're going to give aldosterone antagonists like spironolactone. These are drugs that block the release of aldosterone, so it limits the retention of sodium and water. And we're going to give them stool softeners because we don't want them straining and putting pressure on the vagal nerve because it can slow their heart rate down to a dangerous level. We want to make sure that they have a good diet after they leave. They're initially going to be NPO, of course, while they're out of it when they're having their heart attack. But we're going to progress them to a low salt, low saturated fat, low cholesterol diet. All right, practice question. Patient is admitted to the coronary care unit following cardiac arrest and successful cardiopulmonary resuscitation. When reviewing the healthcare provider's admission orders, which order should the nurse question? Oxygen at 4 liters per nasal cannula, morphine sulfate 2 grams IV every 10 minutes until the pain is relieved, TPA 100 milligrams IV infused over 3 hours, or IV nitroglycerin at 5 micrograms per minute and increased to 5 micrograms per minute by 5 micrograms per minute every 3 to 5 minutes. All right, which sounds like something that might not make sense? And the answer is C. So, patient already had cardiac arrest and they had successful cardiopulmonary resuscitation. We wouldn't want to just give TPA right away. And if we give TPA, it wouldn't be infused over 3 hours. So this is um, our big clot busting drugs. We would only do this if the patient had a SEMI and there was no cath lab or PCI treatment available, and we would be giving it all in one dose, not infusing it over a long time. Okay. Assessment, subjective data. We want to make sure that we are getting a good health history, seeing if we know if they have any valve disease, history of heart failure, cardiomyopathy, any predisposing factors to CAD like hypertension, diabetes. Do they have an history of anemia, lung diseases, high cholesterol? We want to know what medications they're on, and we want to know what happened. How did you get here? When did this chest pain start? How long's it been going on? All of that stuff. We want to assess their functional health patterns. So, what is their family history, their current nutritional status, their elimination patterns, their activity and exercise? Specifically, we want to know how active they are, and we want to know if they have any chest pain, pressure, or palpitations, shortness of breath, dizziness, or weakness with activity. Very important to know those things when we're talking about chest pain and potential acute coronary syndrome. And then we want to also know, like, what is the stress like in your life and how do you cope with things, right? For objective data, we want to know, we want to make note if they're anxious, fearful, restless, or distressed. We want to know what their skin looks like. Is it cool, clammy, pale skin? And then cardiovascular wise, we want to make note if they have tachy or bradycardia, if there's a pulse deficit. So remember, if we are listening to their pulse on like their mitral area, the apex of their heart, and then we're palpating their radial pulse, is there a difference between what we're feeling and what we're hearing? And then we want to make sure that we're monitoring for dysrhythmias. Are there any extra heart sounds, those gallops, the S3 or S4 sounds that sound like Kentucky or Tennessee? Increased or decreased blood pressure and any murmurs that we hear. So any of that like whooshing or blowing noises over the normal looped up S1 and S2 sounds. Also, if they have any diagnostic findings, labs, cardiac biomarkers like troponin, EKG results, if they've had a recent echocardiogram, we'd want to see that too. Examples of clinical problems for these patients are impaired cardiac function, impaired perfusion, pain, anxiety, and activity intolerance. Assessment goals for these patients is pain relief, quick and appropriate treatment, preservation of the heart muscle, setting up goals during hospitalization, to make sure that they're getting up and just start like recapturing their ADLs, things like that. We want to make sure that they have effective coping mechanisms with anxiety, that they have participation in a cardiac rehabilitation plan and reduce risk factors for this happening again. We want to make sure that we're intervening in pain, that we're monitoring their ECG and their vital signs. We want to make sure they're getting rest, that we're managing their anxiety, that we're talking to them about their support systems, that we're providing them really good teaching about discharge and things that they're gonna need to follow up on. And then we're wanna make sure that they understand about physical activity restrictions, and that they want to limit isometric exercises because we don't want them putting a lot of pressure on their vagal nerve. So cardiac rehabilitation is a great program that we refer these patients to where they can work with PTOT staff and registered nurses together to exercise while they're on continuous telemetry. And then they also do like weight management, dietary counseling, smoking cessation, all these wonderful things. So cardiac rehab, really great program, and we should really advocate to our patients to participate and stick with cardiac rehab. It will greatly improve their outcomes. It is important to talk to our patients that have had acute coronary syndrome about resuming sexual activity. Um, and it can be really uncomfortable conversation when you're first starting nursing to talk to patients about their sexuality and sexual activity. But it is very important teaching and it needs to happen. A lot of these patients will be told when it's okay to resume sexual activity, and then they'll also be advised to take like a nitrate, like nitroglycerin, before they have sexual activity. So evaluation of goals, we want to make sure our patients are maintaining stable vital signs and adequate cardiac output, that they are not having chest pain and shortness of breath. They have reduced anxiety and some sense of control over their situation. We want to make sure that they achieve realistic programs of activity through cardiac rehab. And we want to make sure that they can describe the disease process and how to reduce their risk factors so we know that they've gotten good education on being involved in managing their own health care. Sudden cardiac death is a possibility for these patients because of the damaged heart muscle. They can go into an acute lethal dysrhythmia. There are a couple things that we can do to help manage these patients. You don't need to know a lot about sudden cardiac death right now. You'll learn more about it in fourth semester. Really, the thing that I want you guys to focus on is knowing that there is a risk for going into a lethal dysrhythmia after an MI, and some patients that are showing signs that they can have dysrhythmia need to have an ICD placed, which is like a pacemaker that acts as a defibrillator. So if it senses a lethal rhythm, it can provide a shock to the heart and defibrillate the patient from inside the chest. And then after an MI, sometimes they'll have patients wear these life vests, like in this picture down at the bottom here, where there is a defibrillator. Um, there are leads, shock pads attached to the back. So they'll wear this under their clothes and it's attached to this little pack, this little computer that senses if the patient is having a dysrhythmia, it will shock the patient. All right, so practice question. Most significant factor in long-term survival of a patient with sudden cardiac death is, and the answer is B, rapid institution of emergency services and procedures. Really, it's rapid defibrillation. The nurse is caring for a patient who survived sudden cardiac death. What should the nurse include in the discharge instructions? And the answer is C. Your family members should know how to perform CPR and practice regularly. Just because they may have an implanted defibrillator doesn't mean that that is necessarily going to work. So people that are around them and spending a lot of time with them should be familiar with how to do effective CPR compressions. All right, you guys made it. Good job.